Should you take testosterone replacement therapy if you're in perimenopause and menopause? It's kind of complicated. Let's talk about it. I'm Dr. Jen, double-boarded OBGYN and integrative medicine. So testosterone in females is complicated whether or not you need replacement therapy. First of all, not everyone does. Some women actually make adequate testosterone and do not have symptoms such as low libido, brain fog, losing muscle mass, and they don't actually need testosterone. So remember, testosterone is an anabolic steroid, so it helps build, right? And just like all sex hormones, it's actually made from cholesterol. So we actually make estrogen, progesterone, testosterone from the precursor cholesterol. Testosterone is more than just a libido hormone. So there's actually documented benefits to the brain, to the heart, to the muscles for sure, helping build muscles, right? We know that for years, people take testosterone replacement therapy to build muscles, primarily males, but certainly females can as well. And there's actually good data even looking at it, improving bone density. So actually being helpful for prevention of osteoporosis or reversing some of the changes that occur related to osteoporosis. But in libido specifically, it is essentially, approved for hypoactive sexual desire disorder. And hypoactive sexual desire disorder is when you have loss of arousal or desire, and it's interfering or causing problems in your relationships. Typically, the hypoactive sexual desire disorder, there are more than just testosterone available for treatment. There's actually two medications called Addy and Vyleesi, which are both FDA approved for that. And certainly there are a lot of compounding options as well. So if you want to learn more about HSDD, then check out my other video specifically about HSDD and the options. So for testosterone, right now for testing someone, so do you have to be tested if you're having low libido and might benefit from TRT? You do not have to be tested, and the recommendation does not say you have to test hormones. I specifically do because I really want to know, is this a good choice for someone or not? I don't want to cause hair growth, acne, thinning of the hair, a tear on your chin, the things that you see related to excess testosterone. I don't want to cause those symptoms in a woman if she already has adequate levels. And maybe the low libido symptom is actually related to other hormones. So I specifically test total testosterone, free testosterone, and mind you, free testosterone can sometimes not be completely accurate because when we have free testosterone levels in women, they're very, very low. So sometimes the levels in labs aren't really useful. So definitely total testosterone, DHEAS, sex hormone binding globulin, and then I always test estrogen, the three estrogens, and progesterone. So, and it's really important to make sure first, before we even talk about TRT, is that you need to have adequate estrogen and progesterone. Now I'm saying estrogen because remember there's estradiol, estriol, and estrone. And so I use the word estrogens because it is a family, right? There are three. So if you're not adequately replaced in estrogens and progesterone, then adding testosterone doesn't make any sense because you really need to be optimized in those first two, in my mind, first before you add in testosterone replacement therapy. Especially if we're talking about libido, because libido is very complicated in women. And so you want to make sure that you're actually you have enough of estrogen and progesterone first. So back to checking blood test. So you can't, there are people who do saliva testing, and certainly urine testing with the Dutch test. I don't want to get into what are the differences between those and why you would do them in this video, but I do want to say that I typically do blood tests in a conventional lab so that it's covered by insurance, and you should definitely be asking your doctor for those basic labs. Why do I test sex hormone binding globulin? I kind of describe that this is kind of like the Amazon truck, right? So you have packages on the Amazon truck, but they're not available for you to use until they're dropped off at your door. So sex hormone binding globulin binds hormones. So testosterone, most of testosterone is actually bound to sex hormone binding globulin. So it's actually sitting on the Amazon truck and not available for us to use. When it's dropped off at your door, then it becomes free testosterone, right? It's available, it's free for you to be able to use. So you want to know what is the sex hormone binding globulin value as well, because it does matter how much is bound and how much is free. Because as estradiol declines, as we go through perimenopause and menopause, our estradiol levels decline. Our sex hormone binding globulin also declines, which causes more free, there are less Amazon trucks available. So most of it's free and sitting at our doorstep. Hence why women notice when they go through perimenopause and menopause that they start getting these chin hairs and little funky hairs. Their hair is thinning, falling out, just sort of noticing these acne, these testosterone-related effects. It's not that they're making more testosterone, it's that the more of it is unbound. And so it's available, that there's less Amazon trucks, so the packages are out. And so sex hormone binding globulin is also a very important test that I actually check. And I do check it once people are actually on TRT as well. I often check hormones levels in all of the HRT options. If I put someone on estradiol and progesterone, I also check their blood test because I want to make sure they're in a therapeutic range. I will say that that is still even controversial as to what is the adequate estrogen or estradiol level and progesterone level in females on hormone replacement therapy, because currently the guidelines say you do not have to test someone. So again, we're kind of, those of us that do menopause care tend to have a sort of normal range that we feel comfortable with women being on hormone replacement therapy. Okay, so total T, free T, sex hormone binding globulin, DHEAS, because I want to understand where is the androgens coming from. So is it predominantly, do they have androgens from the adrenal glands? Because there should actually be an adequate amount of androgens still being produced from the adrenal glands. The ovaries still continue to make testosterone until you stop. You're not allowed until the ovaries are done. When the ovaries stop producing hormones in general, then they will stop producing testosterone, but they do produce testosterone up until that point. So when I do find out that someone has low testosterone and they are, symptomatic, then we talk about testosterone replacement therapy. Now, testosterone replacement therapy, there is no FDA-approved testosterone currently for females. In fact, it's considered what's called a controlled substance. So just like a narcotic, just like, Percocet, it's which is so incredibly silly that it's put in that category, especially since DHEA is available over the counter throughout the U.S. So I don't know how one hormone, which is an androgen, is available over the counter, but yet the other one is similar to a narcotic. That makes no sense to me, but that's a whole nother conversation, which hopefully will continue to be evolving, and we are, as women's health providers, trying to advocate for that to change. Okay, so testosterone replacement therapy. When we use testosterone replacement therapy, you have essentially two options. One, you can use the FDA-approved testosterone for males. You would use 1/10 the dose, and it doesn't matter which company you're referring to, Testosterone or Androgel or whatever it is, but it's 1/10 of what you would use. So you're essentially, some of these come in packets, and you would, get 1/10 of that packet and use that. Most testosterone replacement therapy is actually placed on the inner thigh, so you just put a little bit on your finger and then put on your inner thigh, and potentially you could have hair growth in that location. So some women actually put it closer to their hairline so that if there is some hair, they don't care because it's in an area where there's already hair. But most women do not have hair growth related to just that low of a dose. The second option is compounding, and I prefer compounding because I know exactly what the dose is. So when you go and make a compounded testosterone regimen, then you have 1 milligram a day or 2 milligram. You know exactly what the dose is because it's dispensed exactly like that. It is out of pocket because no insurance company currently pays for compounded options, nor will they. And so it is an out-of-pocket cost, but it's typically not that expensive to do. From using a FDA-approved testosterone for males, one thing you do have to keep in mind is some pharmacies will not let you pick it up. In fact, Walmart has a strict policy, or at least where I live, that they will not give testosterone approved for males to females unless you're transitioning, believe it or not. So access is a problem. So compounding allows you to be able to do that and not have to worry about these regulations or these rules or someone's personal philosophy about giving testosterone to females. So testosterone replacement therapy, like I said, can be given compounded or using the FDA-approved medication for males, but in 1/10 of the dose. When you're on TRT, the most common benefits that people notice, usually more energy, more interest in sex, ability to build muscle mass. They notice they're not losing as much muscle mass. So as we age, we lose muscle mass. And that's actually a big contributor to what happens from our hormones and all the sort of downstream effects, right? We get more inflammation, we get insulin resistance, all these things happen related to multiple changes that happen in perimenopause and menopause due to our hormones. And so when you're on TRT, people typically notice that they're able to build muscle mass, not become a bodybuilder, or if you wanted to, but not unintentionally become a bodybuilder, but they actually notice that when they go to the gym and they're lifting heavy weights, they're getting the benefit of lifting the weights. Energy, focus, libido. Those are definitely benefits that you know. The side effects can be hair growth in places that you don't want and in the location where you put your testosterone cream. And then at high levels, like things that are given like pellets in my mind, or in my opinion, then those can lead to things like deeper voice, and certainly the testosterone effects that people don't want. So I typically, in my 16 years as an OBGYN, have not seen women who are on testosterone cream that had those side effects. I usually see it on people who are super therapeutic or too high of levels, and that can be in pellets. So I don't particularly prescribe pellets. I think they tend to lead to women having levels that are way too high. And once you put the pellet in, you can't take it out. It's got to wear off, essentially. So I don't use pellet therapy. So testosterone, just to sort of sum this up. Testosterone is an anabolic steroid. Its precursor is cholesterol. You should not use TRT unless you have already been optimized on estrogens and progesterone. And you should get your hormones tested because you may not need testosterone. It may not be something that's actually safe for you. It may lead to more acne, hair growth, and unwanted side effects due to testosterone. So you want to make sure that your levels are adequate. And then you also want to see what are the symptoms that you're treating for testosterone. If it's low libido, if you're not optimized on your estrogen, then you may have low libido anyway. So you want to make sure that those are actually addressed first. Make sure you get your labs drawn before and while on TRT to make sure you're on adequate levels. And the other thing is looking at the other hormones associated with, so insulin and inflammation and all the other sort of hormones that get disrupted by the sex hormones are also important. So if you see a menopause care provider, you want to make sure that they're actually testing all of your hormones. So you should be getting a CRP, you should be getting nutrient levels like vitamin D and B12, you should be getting your sex hormones, thyroid testing. So you should have these fasting insulin. Those things should be tested anyway if you're someone who's 40 on up, regardless. Okay, and if you choose to do testosterone replacement therapy, there are two options: using the FDA-approved medication for males and 1/10 of the dose, or a compounded prescription that's specifically for you at the dose that you and your provider decide. If you have other questions about testosterone, put them below. I'm happy to make a video specifically about those questions.